Welcome to the third lecture on pulmonary function test interpretation. Lecture 1 covered the normal PFT. Lecture 2 covered airflow obstruction. This lecture will cover restriction. This is an overview of an actual PFT performed at University Medical Center in Lubbock, Texas. The pattern of analysis should be familiar to you from the first two lectures. This loop is abnormal, but the abnormalities are different from those of airflow obstruction. The next element is spirometry. The flows are reduced in a pattern consistent with restriction. The next element is lung volumes. The volumes are reduced, which is in contrast to obstruction. The last element is diffusion. The diffusion is impaired and corrects for alveolar volume. This flow volume loop is typical of restriction. The size of the loop is small along both axes. The shape is close to normal and distinctly different from an obstructive loop. There is a nice sharp peak consistent with good effort. There is slight sagging of the sail or scooping of the expiratory limb. Note that the scooping is late during exhalation. We will see in a later slide how this shape affects these spirometry values in a pattern characteristic of restriction. The shape of the inspiratory limb is normal with peak flow in the middle of the rounded hull. There is good closure of the loop, indicating absence of leak or biases in flow measurement. To clarify this point about the different shape for restriction, three loops are shown side by side. The normal loop has no scooping of the expiratory limb. The obstructive loop has very prominent scooping. The curvature occurs very early in the exhalation. This will cause FEV1 to decrease out of proportion to FVC. The restrictive loop has less obvious scooping. The curvature is less apparent and occurs later in the exhalation. FEV1 is not reduced out of proportion to FVC. As we shall see in the next slide, the FEV1 to FVC ratio is actually increased compared with normal. The spirometry values will confirm what was seen in the flow volume loop. The FVC is decreased. There is a ventilatory impairment. For restrictive PFTs, it is appropriate to use the percentage of predicted for FVC to classify the severity of impairment. In most cases of restriction, using FEV1 will give the same category. The FEV1 is also decreased. Unlike obstruction, the FEV1 is decreased in proportion to FVC. The FEV1 to FVC ratio is not reduced like it was in obstruction. In this case, the ratio is higher than normal. The spirometry suggests restriction, but a diagnosis of restriction requires a low total lung capacity. The mid-flow is reduced due to the restriction. This is expected, and there is no special significance to this value in this circumstance. The peak flow is better than both the FVC and FEV1. This indicates a good effort. One cannot diagnose restriction without a measurement of total lung capacity. The spirometry can suggest restriction, but lung volumes are required to confirm the suggestion. The total lung capacity is reduced. This is the definition of restriction. The residual volume is also reduced in this case. This will not be seen in all cases of restriction. RV may be normal or even increased depending on the physiologic cause of the restriction. Interstitial lung disease will have a reduced value of RV due to stiff lungs. Chest wall restriction or neuromuscular weakness can have different results for RV. The RV to TLC ratio will depend on the nature of the restriction. This calculation is not as helpful restriction as it was for the determination of air trapping in obstructive cases. The final element is diffusion. Our examples in the previous lectures had normal diffusion. This case has a diffusion impairment. The diffusion is reduced. 80% are predicted as the lower limit of normal by convention, but the standard deviation for diffusion is larger than for spirometry. Diffusion is an early finding in interstitial lung disease, so diffusion impairment may be out of proportion to the ventilatory impairment in these patients. The DL to VA ratio is normal. This diffusion corrected for alveolar volume. As mentioned in the previous lecture, this implies the loss of entire ventilation perfusion units. The other possibility is selective destruction of capillaries, which would lead to diffusion impairment that did not correct for alveolar volume. I have not found this distinction to be very helpful in clinical practice, but one should be aware of it. This concludes Lecture 3.